Good evening, everyone. My name is William Luis and Gloriani, and this is my report. The Chapter 6, the Organization of Mental Health and Services for Disaster Victims. Introduction. So, in the past, the daycare of disaster victims was limited to rescuing them, tending their wounds, offering shelter and material assistance, helping them to relocate and resume their previous occupation. In the last 3 decades, raising attention has also been given to the victims' psychological suffering and the psychological and moral burden of the individuals and the community. Those programs for medical, psychological, and psychosocial intervention have been designed for nervous countries. They are implemented at different stage of disaster and its aftermath. So the guidance and principles are: number one, to take into account psychological distress. Number two is to manage the psychosocial impact on individual and society. And number three, to prevent the development of the late sequelae to would handicap individual for group functioning. So the impact of the disaster on individual and collective mental health. So in 1980, the World Health Organization estimated the natural disaster had facilitated affect, affiliated in 26 million person between 1900 to 1988. The psychosocial aspect disaster underlined in our definition of disaster by combination of five criteria. One is the occurrence of a negative event that brings disaster to the people and the community. The, the revolution that free country from Traian is not considered a disaster event when accused thousands of casualties. B. The causation of mental distribution that significantly after human environment. An avalanche in an uninhabited mountain valley is not disaster, contrary to the avalanche in a populated valley. Number three, a great number of victims, dead, injured, homeless, who suffered significant somatic injuries and psychological suffering. And the overwhelming description of local means rescue and protection. The last is interruption of services that are normally offered by society: sheltering, producing, distributing, and consuming energy, water, food, health services, transportation, communication, and public order, and even organization of mental health services for disaster of the victims. Number one, a primary victims, dead, wounded, and injured survivors who have been directly exposed to the disaster. The second is secondary victims who have not been directly affected, who mourn close re- rela- relative who are part of the primary victims. So the third one is third level victims such as rescuers, health personnel who intervene on the scene and have often witnessed the traumatized events. Number four, fourth level victims such as government or media workers who may have suffered emotionally when taking discussion or witnessing the scene. So the last one is fifth level victims in the general public who are not physically present at the scene but suffered by the proxy when exposed to the social media coverage. Mental mental condition and healthcare needs to disaster victims. The mental state of victims should be considered at the three different stages of the disaster and aftermath. A. The immediate reaction usually from a few hours to less than a day. B. The post-immediate phase that begins on the second day and lasts from a couple of days to couple of months. The third one is the delayed, long-lasting sequelae that may be transitory from 2 to 6 months or become chronic longer than 6 months. Immediate phase. About 75% of the victims show no mental disorder but only short-lived neuronegativity and psychological symptoms that are transitory, a few hours, and are the part of the normal adaptive stress reaction. A short period of physical and psychological exhaustion may follow because stress depletes energy, and a similar proportion of 25% of the victims may present the abnormal and maladaptive stress reaction, which may follow one of the four patterns: stutter, agitation, panic flight, automatic reaction, maladaptive, maladaptive, maladaptive stress reaction always compress elements of pre-traumatic discussion, including confusion, derealization, free impression of the absence of the relief. So, such a reaction are termed acute stress reaction or acute stress disorder. Post-immediate period. Psychometric symptoms may appear only after a week or months. This is also called latency period, which is being identified in a traumatic neuro, neurosis by Charcot and Janet, and the cold period of incubation, contemplation, meditation, or rumination. Furthermore, if the individual is still hospitalized, he may wait to recover his autonomy to start coping with the trauma. ICD-10 and DSM-4 propose that diagnostic time of post-traumatic stress disorder (PTSD) acute type since the duration is short. For this syndrome, in addition, the DSM-4 offers category acute stress disorder for case with the disruptive symptoms appearing in the immediate phase of post-traumatic symptoms. Delayed and chronic period case of acute stress and post-traumatic stress that occur during the post-immediate phase may resolve spontaneously or with treatment fairly rapidly in 3 months. However, they may also freeze and even become chronic. The typical clinical picture of PTSD may then become manifest during the delayed or chronic period with the key features of one is exposure of the traumatic event, evoking response intense fear or helplessness. Number two, presentary experience of the traumatic event, intro, intrusive recollection, dreams, flashback episodes. Number three, avoidance of stimuli associated with the trauma and numbing of the general responsiveness. And the last one is symptoms of increased arousal. So, according to Finchel, this personality change was characterized by the blocking such function of the ego as one is filtering the environment, presence, relationship with others. So briefly, The victim no longer has same relation with others and the world since the traumatic event. He was developed a new way of perceiving, thinking, love, winning, and acting. In addition to the PTSD, ICD-10 provides another diagnostic category entitled During Personality Change After Catastrophic Experience, defined by criteria such as mistrustful attitude towards the world, social withdrawal, feelings of emptiness, or of being threatened, and estrangement, mental state of the affected community. Adaptive collective behavior, the often shared and expected instance of the adaptive collective behavior during the implement phase, rhyming one proposed ordinary evacuation, helping others. Adaptive collective behavior and characterized by the three features. Number one, a group structure preserved. Number two, leadership and maintained. A reset established. Number three is mutual help is organized. Sorry. During the post-immediate and long-term phase, adaptive collective behavior is manifested by normal neuron regaining autonomy, reconstruction, and resuming normal professional and social activities. Mala- Maladaptive collective behavior during the immediate phase may show us. So, collected sputter, the population remains reactionless or evacuates the impact zone in a long centrifugal exodus. Two is collective panic, holding fight, scrambling for safety, or exodus. These three types of collective behavior are characterized by A. The losing of the group's structure. B. The collapse of the leadership. C. The lack of solidarity. History of mental intervention after disaster. The detection and treatment of mental disorder caused by disaster began in the USA, thanks to the adapt, ad- advent of the PTSD diagnostic category in the aftermath for the Vietnam War. As early 1983, Mitchell trained def, defined debriefing procedures of the bias of cognitive techniques. His methods aimed at treating police officers or firemen who had been exposed to the critical event. Mitchell's method can be applied during the post-immediate period. First week, it follows a seven-step introduction, facts, thoughts, reaction, symptoms, ida, ida, educa, education, education consolation. Mitchell's approach is mainly cognitive. It helps the patients to gain an exact knowledge of the event. It aims at prevention. Lack of knowledge might lead to PTSD and restoring operational capability. Mitchell debriefing techniques are modified by several authors. Some establish a distinction between didactic, psychological, and rheumatic debriefing. Others place debriefing in a continuum of care. It emphasizes the importance of coping mechanism and cognitive structuring. After the San Francisco earthquake earthquake in 1989, Armstrong 1921 developed a multiple stressor debriefing model taking into the account all stressors and comprising four steps: disclosure of the event and alertness, feelings and reaction, coping strategies, and conclusion to return to the familiar group. In 1992, they grew to develop a collective debriefing method which made us of the group's capacity to provide mutual help. In France and Belgium, this briefing has been based on the verbal expression of the experience, both cognitive and emotional, and considered to be an early therapeutic intervention which could be followed by longer-term management. It's only in the 1900s that American authors started proposing more comprehensive management programs that include reducing symptoms in previous experience, that avoidance, and restoring emotional control, incorporating the proposal's significance of the event and social tension and similar initiatives helping in Europe at the same time. In the United Kingdom, the police used to take care of the initial psychological needs of the victim before medical and social service intervened. In Norway, the military is charged for first aid, including psychological and post-traumatic resistance. In intervened as early as 1985, the factory fire and an avalanche site. In Sweden, psychologists and psychiatrists practicing civilian hospital will also evaluate and treat victims, as was case, for instance, after the rail conciliation at Lerum on the Stockholm to go Telbridge line, which caused 9 dead and 100 wounded on November 16, 1987. In Latin America, the Pan-American Health Organization or PAHO has been actively engaged for the last 20 years efforts to assist disaster victims, in particular after hurricanes in the Caribbean. The first strategy considered standing teams of the affected community. In ASEAN countries, the recent earthquake in Kobe, Japan on 17 January of 1995 showed that installing a mental health service in a disaster area is fraught with difficulties. The Hanshin Nawaji earthquake left 5,500 dead and 300,000 homeless. In that contribution, 1.5 million local authorities are overwhelmed, could not respond immediately in adapt manner. In 2002, Raquel Cohen worked a survey of a mental health intervention with disaster victims, and she stressed that mental health intervention should be integrated within the larger frame of the public organization of rescue operation and establish links with other partners. So, so organization of mental health services for disaster victims. The organization Mental Health Service for Disaster Victims should be able to answer the following questions. So number one is what type of the disaster, two which which victim, what are type of mental dis- disturbance, and they vary according to the victims and the stage of the disaster. What type of emission, which personnel, what is the administrative frame. So what are type of the disaster? So the nature and severity of the disaster will be influenced the mental symptoms presented by the victims and the government or local authorities approach. So natural disasters such as earthquakes can concern many people cover wide area and the last significant length of time. Technological and industrial disaster, train or plane crashes, sinking boats, explosion or in fires in factories are usually limited in a space, which simplifies the organization for rescue operation. Also, bombings cities like Dresden, Tokyo, Hiroshima, and Nagasaki worldwide to exercise entire city. Which victims? So mental health teams will be first have to take care of the primary victims of the disaster, with those who have been in indirect contact with the disaster. Also, a few witnesses and rescuers who have been shocked by set of death of the destruction may have been taken care of fairly early. Later on, it will be necessary to assist secondary victims such rumoring relatives evacuated population. Thirdly, rescuers and health personnel will be have to assist to cope with the stereotypes experience at different stage of the disaster. Even arriving on the site because of sudden confrontation with rock, etc. During the phase of maximum activity because of various stressor or working rapidly and dangerous condition, lack of sleep, the guilt includes by the trage and the impossibility of spending enough time with the individual. So the final post-disaster evaluation to impression the task was not complicated or having failed. What types of mental disturbance? The types of disorders occurring during the after disaster have been reviewed above. Briefly, the immediate phase may be associated with distressing symptoms, accompanying adaptive stress symptoms of maladaptive stress such as confusion, agitation, panic flight, automatic behavior, and ex- exceptionally neurotic or psych- psychotic reaction. The past, the post-immediate phase may be characterized by return to normal health or by the insidious onset of a post-traumatic syndrome of PTSD or PTSD. Right? So the chronic phase may present with the persistence of PTSD or persistent change. What type of mission, organization, coordination, planning? In many countries, organizing the initial rescue operation is the responsibility of the government or its agency that serious level, federal, provincial, and the town. For example, according to the severity of the disaster, the most important factors is the presence of the clear organization, preventing unnecessary tasks, timetables, place, and factors should be clearly defined. It has been too often the cases that NGO members have been with excessive independence and fearing that when a task had been assigned to others, reporting only their own headquarters. Evaluation of the mental health needs. A second, a second mission is evaluation among the mental health personnel at the scene. One psychiatrist must assume in this task, even the means that treatment action will be taken over by the one of his colleagues. On the basis information contributed by college, colleges. And the first aid staff is this psychiatrist has to evaluate of the number of psychiatric casualties and the types of disorders that are present or will occur soon, like stupor, agitation, or panic. So, traits of psychiatric casualties. In many disaster, advanced advanced rescue stations on the scenes are flooded by sudden influx of the casualties to the point of that risk being knowledge and paralyzed. Those traits on initial traits means establishing a diagnosis, even if provisional. So the diagnosis along with the main symptoms should be indicate on the records and the documents that accompany that patient would be when he was evacuated to the near medical and psychological care. It was often mentioned that the material and physical help given by the first rescue team on the site also has beneficial psychological effect on the victims. The arrival of the first rescue team on the site expressed the victim's feeling of isolation. Those close physical contact resources of the patient envelope. Victims presenting with mental symptoms can be treated only by medical teams. However, other victims with mental symptoms can be taken care by psychosocial workers. The psychological and psychi- psychiatric methods employed are left to judgment of the mental health teams concerning antidepressant or hypothetic drugs, brief psychological support, verbalization of emotion, which personnel. So generally, mental health is the province specialized personnel, psychiatrists, psychologists, psychiatric nurse further the most support, ultimate administrative and paramedical, like Red Cross personnel is required. During the immediate phase, rescuing the wounded usually the task of the volunteer or professional first aid team. who will carry the victims to stretcher to the first aid station. These paramedical personnel are often the victim's first contact. Therefore, they should be given some psychological training about the needs of the victims and how to approach them. What is the administrative frame? Mental health usually under the control of the government, notably Ministry of Health. Therefore, it is understandable that mental health in time of disaster would also be controlled by the government authorities. Even the NGO, Red Cross, private practitioners, volunteers, and many take part in relief operations, especially the emergency plans are prepared by the government administration with the advice of experts. When disaster strikes, intervention of the site must ultimately coordinated by the government authorities. This is applies of of course to the logistic. It is also applied medical relief, physician and other health and paramedical personnel on the site have to be integrated into the hierarchical structure in the frame of pre-existing emergency plan. Now, three examples of system of mental health intervention. First, the French system for medical and psychological emergency. Number two is the European Red Cross Society Network for Psychological Support, or E ENPS. The third is interface between judica- judicial protection and mental health. The French system for medical and psychological emergency. The impetus for forming a French system for medical and psychological emergency started in 1995 in France. This system arrived as camp or colleges under the agents de psychologistics, a directive from Ministry of Health's office officially created the system on May 28, 1997. The creation of the system, supervised by the Louis Croc, a French army psychiatrist with a long experience in stress and traumatic news. This system comprises about 100 cells, one cells in each French department or country. In each department, a government-employed hospital-based psychiatrist volunteered to coordinate a group of voluntary psychiatrists, psychologists, and psychiatric nurses. Their mission is to arrive as soon as possible on the site in the case of disaster, territory, terrorist attacks, etc. These cells are meant to intervene when there are large number of casualties in collective disaster. Europe, sorry, European Red Cross Society's Network of Psychological Support, or ENPS. So European Red Cross Crescent Society's Network of Psychological Support (EN) was established in 2000. The objectives of the ENPS include: number one, taking inventory and share experience and practices in psychological support in the national European societies. So, This includes the action of the team training programs adapted to the cultural sensitivities. Number two, establishing and developing the speciali- specialties of the psychological support of the Red Cross movement at the Europe level. Number three, setting up cooperation between the national societies, the authorities, and European institutions. The last one is the working in the contact with the International Red Cross Reference Center psychological support based on Danish Red Cross. So on this interfact between judicial protection and mental health. So the disaster victims have been suffered loss, damage, or injury to their person opportunity. Sometimes this may have occurred through the omission, negligence, or lawful acts of others. Therefore, they may be entitled to the pecuniary compensation or immediately. Besides the purely judicial aspects, the fact that damages are awarded to the responsibility and established by the law court can help healing process. Consequently, judicial process, the experience of testifying containing containing one's experience established proof my reactive symptoms such as intrusive recollections or distressing dreams of the event. So conclusion. The object of the mental health care disaster victims are also alleviate psychological distress to manage social impact on the individuals and community and to prevent development of the late physical, physical, physical sequel, sequelae. The organization in mental health care must be planned in advance, taking into the account that disaster is deeper in the types of severely mental health intervention must be initiated as soon as possible on the site in the immediate phase. So, first in the first hours. So, but it should also cover the post immediate, the second day until the 2 months, and the chronic phase after two months. Further, it must be adapted to the specific disorder occurring in each of those three phases. Treatment must have given permanent primary primary victims who have indirect contact with the disaster, secondary victims, the relatives, and the tertiary victims, the shocked and exhausted rescuer and care- caregivers, the fourth victims, leaders in the media who have witnesses, and even the fifth level victims population shock through media. So official can supervise organization, coordinate on the relief population including the healthcare in the immediate phase. So evaluation and regimental mental casualties are essential.